I have them here.
You're live?
Okay. TikTok.
Three, two, one.
The chaos that is this show. I love it. Welcome to a Chaos Show. It's actually Fertility Fact or Fiction. I am your host, Dr. Rahi Victory, double board certified reproductive endocrinology and fertility specialist. And I am not at ASRM, where I probably should have been, but my office wouldn't let me go because we were too busy. And I am here with my esteemed colleague and host, the one and only King, Dr. Derek.
Hello, everybody.
Ibrahim, I almost said Victory.
I can be a Victory for a little bit.
There you
problem.
go. Honorary Victory, who is neither a king nor a doctor, but he is the master of all things social media. And he is here with me tonight. And we are going to be answering questions because I couldn't find any good articles for this week. Although there is some interesting information coming. So there is some cool stuff that's around the corner. And I'll talk about some of that. So I'm excited about some new things that I've learned. And talking to a friend of mine in England. So I doubt she's awake watching the show now. I certainly hope she isn't. But my dear friend Elena, who is super smart and has looked up more than I could ever even imagine. So she introduced me to a couple of new things we're going to be doing some research on and trying out some new ideas. So one is whether or not your thyroid T3 level impacts your success rates. And we don't routinely measure T3 levels, but I'm actually going to start measuring T3 levels. And I think that that is kind of huge and important. The other thing that she talked about is whether or not your nitric oxide levels are appropriate. And that's also not something we've ever looked at, but there is a really easy saliva like dipstick test. You literally just like put the stick up against your tongue and it tells you whether or not you have enough nitric oxide. And apparently if you improve your nitric oxide delivery, you can actually improve your responsiveness in cycles. So we are going to try some interesting new tweaks and tricks. Also very proud to announce that VRC's genetics program is now up and running. We ran our first batch of PGT. And we are able to tell all sorts of things like, is it the mom that's responsible for the mutation or the dad? We're getting very, very high level in-depth reads, higher than the commercial guys are getting actually. And we've had tremendous accuracy. So we are very, very excited about our program. And for many patients, it's actually going to be cheaper than what they were paying before. So we're also very excited about that. So VRC PGT is now underway. It'll very soon become a separate company. And so we're excited about that as well. We have some other things coming up. So we'll have a comprehensive program.
Amazing.
Yeah, very excited about that. Yeah, it took a while. It took us about a year and a bit to get it up and running, but it's now up and running and we're super pumped about that. And yeah, so that's what's happening in the wild world of infertility. Also, for those of you that are fans of the show, I will say that I have to do an exam every year. And the exam is not exactly an exam. You have to read a bunch of articles and then you have to answer questions and you have to maintain a very high average. And then you don't have to actually write a written exam. And so this is for your American board certification. So one of the articles was super interesting because this particular article demonstrated that if you have a high dose of medications, you actually have a higher rate of mosaic abnormal embryos. So I wasn't aware of that study. I hadn't seen that one before, but I thought that that was really telling because I'm constantly telling people not to take high doses of meds because it's terrible for your egg quality. And sure enough, it's actually not just terrible for your egg quality. It actually increases the number of abnormal embryos you're going to get. So very, very interesting data. Maybe we'll review that on an upcoming show because I thought that was kind of cool. And more patients should be telling their doctors not to give them high doses. I talked to someone recently who was on a total dose of 450 and had a very poor cycle outcome. And the response of the doctor was, you need more, you need 600 plus. And my response was, no, you should try natural cycle IVF or mini stim, because your most likely problem is they gave you too high a dose and your eggs just don't like it. So very cool kind of data, very interesting stuff coming out there. And so we should be seeing some changes in practice habits, hopefully, if the doctors are actually paying attention. On another note, I had another patient talk to me today who is seeing another fertility specialist in Ontario. Hard to call this person a fertility specialist. They don't have formal training, but they practice in the realm of fertility, shall we say.
Wait, hold on. Somebody's doing what I'm doing and getting paid for it?
No, this is an OBGYN.
Okay.
Who practices in infertility. And I don't want to get too detailed because I don't want to get anyone upset, but doesn't have formal fertility training, but kind of dipped their toes in and has now been doing this for quite some time.
Mm-hmm.
So this individual told the patient that adenomyosis did not impact fertility.
The good old, it doesn't matter.
It doesn't matter. So I said, well, actually, that's just not exactly true. There's some areas where it does impact. Here's where it impacts, and so on. So it's interesting that the misinformation is still out there.
It's not going anywhere.
No,
it's not going anywhere.
Yeah. And for those of you that have not seen our TikTok or Instagram lately, there's a great video of how life begins with a little sperm that detaches and travels, and it gets selected as the one, and then all the other ones bounce off the egg. So please check out that video, and please share, because it's always fun when these things go viral for us. So with no further ado, I'm sure we have 10 million questions.
We do have a bunch of questions, of course. First of all, everybody's super happy to see you, Dr. V. That's how it starts. Hi, Dr. V. Hi, Dr. V. Why do embryos arrest after day 3?
After day 3, it's usually from sperm. Before day 3, it can be egg related, possibly sperm related. But after day 3, it's typically a sperm problem if the embryos start to arrest. So you have to look at the sperm and see, is there too much oxidative damage? Is there too much reactive oxygen species there? Is there DNA fragmentation? Were they mature? The different things that we look at in the sperm. Sometimes are they aneuploid? There's a bunch of different tests that can be done, which are way more advanced than the garden variety. Here's your sperm test. That's the other thing. The same facility that told this woman that adenomyosis didn't matter was using a sperm diagnostic test that's like close to 20 years old.
They got it on the cheap.
It's no, like their reference range is from World Health Organization
20 years ago.
And I think it's undergone at least 3 updates since then. No update. Still using the oldest technology. It's just like, what? Yeah. Can't do that.
Well, what I understand from that is not everybody can be Dr. V.
Oh, well, anyone can be me. They just need to be honest.
A very good question the audience is asking.
Okay.
Where is your doctor coat for Halloween, T?
Oh, okay. So full fairness.
Yes, Dr. V.
I have scrubs for him. And we've been talking about the fact that he should wear scrubs. And they are in my office. I could leave you with Tarek for a while and I could run and grab it if you want, but it would take a minute from the show. So
I can answer questions in the meantime.
Yeah, you could answer. He looks kind of doctoral. He's got the cardigan on.
Yeah. I'm like the doctor that's like, post call, just sitting down, chilling. That's right. Dr. V and Dr. T. Would a person who has tetraspermia, teratozospermia, qualify to be a sperm donor?
It depends on how bad the sperm is. If you've got pretty high percentages, probably not. Like a high percentage of abnormal sperm, you probably wouldn't be eligible. But if it was like borderline or something, you'd have to talk to the sperm bank or the person accepting your sperm. Not ideal, that's for sure.
Would you recommend omnitrope priming for transfer?
For transfer, you don't prime with it. You inject it into the uterus, and that's been shown to be beneficial. Yes, in that circumstance, but you don't normally prime with omnitrope to do a transfer.
Is it okay to exercise and stretch during and after egg retrieval?
Exercise is fine, just nothing too intense, especially before and right after. Because if your ovaries are quite large, they're at risk for torsion. And if you're bouncing around or doing like a HIIT training class, you could tort your ovaries. So we never recommend sort of aggressive exercise at that time. Light, moderate exercise is not a problem. That's fine.
From TikTok.
Yeah.
Hi, Dr. V. I'm a patient of yours and just had endo surgery.
Okay.
Thanks to you, stage 3 endo, 0 symptoms.
Oh, that's awesome. Congratulations. I'm glad to hear that. I appreciate the feedback. That's really very, very good. Not bad. Yeah.
Absolutely.
Yeah, very good. I'll let Dr. Mayran, my assistant, know too.
My name is Monica.
Okay.
Not my name, obviously.
I get it. Yeah. I didn't think you'd gone.
No,
that
I didn't. Way. I am not Monica. As of right now, I still am Tariq. Yeah. Just so everyone knows, like it's a valid question. People might get confused. I've had 3 failed FETs with genetically tested embryos.
I'm absolutely calling you Monica.
That's my new moniker now. I am now Monica. That's what happened on the show. Well, thank you, Monica.
Okay, so Monica has had 3 what? Failed euploid transfers?
She had 3 failed FETs with genetically tested embryos.
Okay,
is that the same thing?
Euploid, transfers, yeah.
Because I believe we have to say what the people are saying.
I feel you.
You know what I mean?
Yeah.
I'm not going to assume that's what that meant.
No.
What else can I do?
Oh, yeah. So shape of your uterus would be important. Detailed 3D saline infusion sonohystogram by an expert who knows what to look for. Sperm quality testing for sure would be critically important. Vitamins, thyroid, microbiome, immunological profile, thrombophilia screen. Those would be the basics we would start with. You should basically reach out to us. We know what to do in those cases almost every time.
From our good friends at YouTube, the YouTubers, thoughts on Hep B shot at birth. Here you go, man. You wanted it. You got it.
Oh, God. Okay, listen, I'm not a pediatrician and I'm not a vaccine expert, but the hepatitis B vaccine is designed to prevent hepatitis B, obviously. And your risk of getting hepatitis B is very much related to what your environment is like. So, if you're exposed to people that are IV drug users or sexually promiscuous, or you're in an endemic area like Southeast Asia or something like that, you need it because you're going to be exposed. But a baby in Canada or the US in a upper middle class family, do you need a Hep B shot at birth? I have not seen the evidence, so I don't want to make any inappropriate statements, but I mean, I would be questioning why the kid needs Hep B at birth if the chance of acquiring Hep B that early in life would be negligibly small. Do I think that the vaccine is harmful? Absolutely not. But do I think you need it right at birth? Not unless you're coming from a hepatitis positive mom. No.
Pretty good answer, if I may say. You towed the line of science. You did it right.
Did I?
I think so.
Did I get it?
You did it. I think you got it. Hi, docs. Wow. And the good life begins.
Can we throw a shout out to Heather?
Heather, absolutely.
Your brownies, like hands down, legend.
I had some, and I must say they were absolutely delicious. Yeah, they were fantastic.
And thank you for including Tariq as one of the recipients of your spectacular brownies. They're legendary.
Can I say that I bragged to almost like 20 people about the fact that I even got these brownies? Like I actually went around saying, look. So it was
They are very good brownies.
Pretty good moment.
Yeah.
Dr. Victory.
Yeah.
They are wondering, 35 years old, AFC of 18, AMH 16, unexplained infertility. During growth stims, I had uneven follicle growth and as a result, fewer mature eggs. Testosterone priming didn't seem to help. Any thoughts? Thank you.
So I would want to know what your stim protocol was, like what meds were you on, what dose of meds were you on. I'd probably consider using something along the lines of human growth hormone. I don't do estrogen priming, but there are some people that respond, so that's your next step as well. So there's a couple of different ways you could line up the eggs. The alternative would also be to do a luteal phase cycle, right? So you could always see if you line up better in the luteal phase than you did in the follicular phase.
Hello, Dr. V. Oh, zoomed out too much. And King T. Fantastic. Yeah, just go a little bit more. Bring it in. No, other way. Other way. A little bit more. A little bit more. A little bit more. Keep coming. Don't be afraid. Oh. Good. Good.
Are you focused?
Fantastic.
Excellent. Good. Excellent. All right, fire away.
Continue on this lovely question here. Yeah. Curious about how you approach a standalone luteal phase stimulation. Could you walk us through what you look for before starting? For example, how you confirm ovulation has occurred, whether you use LH strips, blood work, or ultrasound, and what findings on ultrasound would tell you it's the right time to begin. Want to know all the details, please.
So we actually use all of those methods. So if you want to just do it with an LH strip, that's fine. If you want to come in and confirm with LH monitoring, or you want to confirm with doing, let's say, ultrasound to confirm that the follicles collapse, we can do all of those. To be honest, we actually offer a package where we do a natural cycle egg retrieval followed by a luteal phase. Some of our patients really like that because the natural cycle retrieval is dirt cheap as part of that package. So we offer that as well. So you're not letting that first egg go to waste, in which case you're actually triggering it, so you know. And then based on the Viotti article back in Fertility and Sterility, we wait 5 days and then we start your stim. Occasionally less, like 3 days, depending on the size of your follicles, but typically 5 days, and then we just start your stimulation. So that's how we do it. But it doesn't really matter which way you determine it. You can actually start a cycle at any point in time. We're just kind of ingrained in our heads to start it follicular on day 2 or 3 or 4 being a bit late. And then luteal, everybody's done the 5-day thing because that's what the original article talked about.
Dr. Victory, do you think the
Adenomyomectomy?
Probably.
Okay.
Is worth a shot if we cannot afford a surrogate.
Yeah, sure. I mean, it depends on how big the adenomyoma is and how badly damaged your uterus would end up. But there's no question that if you've got an adenomyoma or fibroids and you just need to fix them, you should. I actually spoke to a patient tonight, late afternoon, from BC, who has multiple fibroids and was considering a surrogate. And I was like, why do you need a surrogate? And she said, well, I had all these fibroids. And I said, okay. Like, I wrote a chapter for a gynae textbook. My chapter was fibroids. I can take out your fibroids. So let's save you a ton of money and you won't have to worry about this anymore. And she was quite interested in that. So you don't need to have a surrogate unless you've really given it your all and it hasn't worked. Now, am I saying there's something wrong with surrogates? No, we love our surrogates. We do a lot of surrogacy, and in many instances, it's necessary. And God bless them all. They're amazing women, true, giving people. So I love that for the people that need it. But if you don't need it, do you have to do it? No, you've got options, and review your options and make a decision that's right for you.
So what's your take on having the surrogate because of fibroids?
Well, to me, it wouldn't make a lot of sense. Like, fibroids you can remove, right? So like, it's not a complicated surgery. Yes, the Canadian medical system sucks and it takes forever to get into surgery, but there's no question that you can get your fibroids removed. The surgery is risky for some people, but if you have an expert surgeon, it takes away a lot of the risk. If they repair the uterus properly, which some don't, layer by layer by layer by layer till it comes back together. You don't have to worry about rupture as much. And as long as you have an expert who knows how to avoid adhesions, knows how to minimize bleeding, knows how to take care of you in and out of the surgery, they can restore normalcy to your uterine anatomy. I've taken upwards of 30 fibroids out of one uterus, and it was a perfect uterus afterwards, and the patient got pregnant. So as long as you know what you're doing, you're perfectly fine. It's when you get either a surgeon who doesn't know what they're doing, or you get a doctor that tells you you need to go directly to a surrogate, that it's a problem, because they're not giving you all of your options. And patients deserve to have options. They need to have the options so that they get fully informed. Can you ever really be fully informed if you didn't get all the options? No, of course not. So it's critical your doctor review the risks and benefits with you and tell you, yeah, I can take out your fibroids. Why don't they? Expediency, right? Like efficiency. It's way faster to do IVF on you, put it into a surrogate, than it is to wait 6 months or a year to get you into surgery. And that can often mean a financial loss for the clinic, because they're not getting to you to do their IVF. And so they kind of look at that and go, well, maybe this isn't great for the clinic. The reality is we shouldn't be doing what's great for the clinic. We should be doing what's great for you.
Yes, that's right. What is your opinion on transferring low mosaics, for example, LLM del 6Q?
So that's a segmental low-level mosaic embryo. And what that means is that there is a very good chance that that embryo is genetically normal. The most recent study, which came from a large company in the States, demonstrated that in over 9,000 embryo transfers with mosaic embryos, the outcome for low-level segmental mosaics was the exact same as a euploid embryo. They didn't have a difference in the outcome when the doctors were actually blinded to whether or not these embryos were normal. So there's no question whatsoever that those embryos are perfectly reasonable, and we use them. Look, PGT has changed drastically recently. Okay. Again, as part of the exam studying thing, there was another article on PGT I was evaluating as well. We know for sure that PGT should not be used to discard embryos necessarily. Yes, if they're true aneuploids, they have a very low chance of resulting in a real pregnancy. Very, very low. How low? About 0.7%. So kind of not worth doing it, especially if you have to pay for these embryo transfers. But pretty much every other category of embryo has some chance. So example, low-level mosaic, same as a euploid. High-level mosaic, a little bit lower, but there's still a chance, somewhere between 20 to 35%, depending on which study you read. A complex abnormal, anywhere from 30 to 50%, that it can actually be a completely normal embryo. We just retested one of our patients' embryos who bizarrely had done donor egg, but had a high rate of abnormal with a big commercial company that we use. So we said, you know what, we're just going to retest the embryos. Two of the ones we tested came back normal. And they had come back horribly abnormal from the big commercial company. So sometimes it's not always accurate when you have these complex abnormals. And then if you have a segmental aneuploid, which means that a portion of a chromosome is either duplicated or deleted, but it's in over 80% of the cells, 24% of those can become babies too. So don't use PGT to discard embryos, and don't let your clinic tell you that they're not going to let you use them. You have to fight for your rights, and you have to say, I want to use them. You'll need genetic counseling, reasonable. You may need social work counseling or psychological counseling, reasonable. You need a very in-depth review of the outcomes, because you may need to terminate a genetically abnormal baby if it has no chance of life, or you're not willing to have a baby with those sorts of problems. But don't use PGT to destroy embryos. Use PGT to rank which embryos you should use first, so that A, you get a faster time to pregnancy, proven, and B, it may be financially more advantageous for you because you're doing less embryo transfers before you get pregnant, which means there's a cost benefit for you as well. So that's why you do PGT. Do not use PGT to discard embryos. That's crazy. It doesn't make sense anymore, because we know a lot of the embryos actually have a chance. It's the true whole chromosome embryos that are aneuploid that have a lower chance. Everything else, there's actually a chance of success.
TikTok, they're not liking enough today.
Oh, they're not liking enough on TikTok. Our TikTokers, please like more. Tark gets very frustrated when there aren't enough likes.
Yes.
Yeah.
We need to see love and support.
Love and support.
Shares, likes, all those good things.
Diamonds, whatever diamonds. I still don't understand
Yeah,
TikTok.
yeah.
I don't understand TikTok.
I think in
but
America, it gives you money. In Canada, it gives you just a nice diamond.
You and I have made how much off of Instagram so far? 0. TikTok, 0. We're not making a lot off of this show. Yeah. Sum total, it's probably cost us
way more than that.
A lot.
Way more than that.
A lot. Yeah. Our meals every week cost us more than we.
That's for sure.
Yeah.
Royal King Tea.
Oh, love that. Yeah.
Royal. And the great Dr. V. Nice. Very nice.
They're learning their way to your heart.
They're in. They're in. These guys are fantastic.
Yeah.
Thoughts on HOCATT ozone sauna to increase euploid rate for retrieval? There seems to be a few PubMed literature on it. Any recommendation on the number of times per week or protocol?
I don't know what HOC blah 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 blah.
HOCATT?
Yeah.
HOCAT.
No idea what that is. The only ozone sauna studies I'm aware of are from Dr. Merhi, who's the big PRP guy in the States. He had, I think, 2 research articles on it. They were, in my opinion, inadequate to convince me to use it, so I don't believe in it. However, Tarek is currently working on a video that we made together in relation to hyperbaric oxygen therapy. And hyperbaric oxygen therapy does actually appear to be beneficial. So I'm a believer in that. Maybe ozone sauna is the greatest thing ever. There's just no evidence yet.
I think HOCATT could be hyperbaric oxygen chamber ATT.
No, that's HBOT, hyperbaric oxygen therapy.
Maybe they just assumed baric is gone.
I don't know.
Hyperoxygen chamber.
You think?
Yeah.
Let me look it up. It's
HOCATT ozone sauna.
HOCATT.
Yeah.
Advanced 10-in-1 ozone sauna wellness system.
There you go. See? Dr. T to the
The
rest.
hell is that?
There we go.
Look at that. It's like a coffin they put you in.
It's always a scary thing that you go into. That's not a joke.
You're not catching me in that sucker.
That is from a person that actually went into a hyperbaric chamber before, I'll tell you, if you have 1% of what's it called when you hate closed spaces?
Claustrophobia.
If you have 1% claustrophobia, do not proceed. Do not collect go.
Yeah, you wouldn't be getting me in this sucker. No. I don't see enough evidence to believe that makes a difference. Oh, and Gary Brecka believes in it, which automatically means you shouldn't do it.
Scam?
Oh, that guy's full of nonsense. Yeah. Yeah. So I don't know. Maybe I just, I have trouble believing that it'll work. But anyways, go ahead.
Hi, Dr. V and Royalty. It's just getting better and better. When would you choose Recavel over Gonalev?
Listen, I am not going to get into trouble with anybody by recommending one drug over another. We're not allowed to in Canada in order to maintain our ethical standards. However, I do think they're both good drugs. I think that there are indications. And if you're my personal patient on a one-to-one basis, I would be willing to talk to you about what I see with one drug versus the other. And sometimes we try one and it doesn't work, and we try the other, and we try the other one and that doesn't work, and we try the first one. So there are various indications for each one. I think they're both good drugs. I use them relatively interchangeably. We have seen very good results from Gonalev. We have seen very good results from Recavel. So I don't necessarily discriminate too much between those two. Certainly not live on TV anyways.
Dr. V, what is your opinion on transferring? Oh, we did that. The low mosaics. We did that. Hello, greatest Master T.
Oh, come on.
Wow. Wow. Big one. Big one.
Come on now.
That's serious.
Yeah.
Of course, I want to answer this question. And Dr. V.
Yeah. ordinary Dr. V.
I just let it sit there for a minute. Let the audience
Yeah,
decide
I'm
which
just gonna-
name they like better.
I'm going to crawl under the desk now. Yeah.
In my USL,
Yeah.
IVF meds, Recavel 9 mcg,
Yep.
Menopur
Yeah.
150 units.
Yeah.
Is this a good protocol, and how affected could my egg quality be?
That's a reasonable protocol. You're taking a total dose that's just under 300. It's not bad. I wouldn't argue against that. Depends on what your history is. You didn't give me very much information there, but not bad.
Hello, Dr. V. Looking forward to you getting me pregnant.
Excellent.
Wow, that's a very
loaded question.
That's a loaded comment.
Nah.
You say that in the wrong place at the wrong time.
I got a very understanding.
Just so you know, they also wrote down "lol" at the end of it.
Yeah,
because they know what they wrote.
They knew what they wrote.
I know what I read, but they know what they wrote. I will be doing IVF with your clinic in December or January.
Okay.
What can I do to prepare? And do you recommend ICSI for my husband with low sperm counts?
Well, we do ICSI for everybody because it improves the success rate. So that's easy. What can you do to prepare? Lots of vitamins, daily exercise, meditation, yoga, loads of supplements. Make sure that you are eating very healthy. The Mediterranean diet is best. Make sure that you are ensuring that your husband is ejaculating every day or every other day. No smoking, no drinking, no drug use for either of you. And that includes marijuana and all THC, CBD products. And then in addition to that, make sure that he is taking supplements, vitamins, doing all the healthy dieting things, and keeping his testicles cold. All of those will contribute to an improved level of success. Stephen Palter put out a post the other day where he said, that your doctor needs to pay attention to the holistic approach to things. And sure enough, I commented on it. I said, I think he and I are like two of the few that actually focus on that. And most people don't. So I think that's really critical and important. And a holistic approach will help you do better. So make sure you do that. And hello, Stephen, if you're watching, he's currently in Texas at ASRM.
Everybody's there, right?
Yeah. Including Adam,
Including
who gave
Adam.
a talk for us.
Oh, really?
Yeah.
Oh, cool.
Yeah.
Dr. Victory, I want to make a consult with you so bad.
Okay.
But
it's a forever wait.
I'm in Michigan.
Oh, well, that's easy.
How long after hysteroscopy should I wait for FET?
That's the same person?
No.
Oh,
this is not the same person.
Michigan is nothing because you're right across the border. You can either come here and meet me in person, or you can just do a Zoom with us. So that's easy. We can easily accommodate Michigan. How long should you wait after hysteroscopy to do an FET? A month. I mean, it depends on what they did in your hysteroscopy, but typically a month is enough unless there was major surgery involved. Like if they took out a fibroid, if they did uterine reshaping, metroplasty, hysteroplasty, septoplasty, that kind of thing, that's different. But otherwise, generally speaking, a month is enough.
Dr. Victory?
Yeah.
If I'm a patient of yours, but get a SIS at a satellite clinic.
Yeah.
Do you get the images or just a report?
No, I get the images.
I only trust you to analyze my results.
So if it's done at one of our satellite clinics, I get the images. If it's done at somebody else's place, not usually, unless it's Tripod in Toronto.
Oh, look at this. BFF Tarek.
BFF Tarek. You just sopping this up,
literally
man.
fast forwarded. I'm like, BFF. Oh my God. Hi.
Okay, you guys are creating a monster. He's a sponge for this stuff. All right.
I consider myself completely neutral in picking all comments and questions.
Excuse me. Sorry.
I just so happened friendly salutations. Nothing wrong with that.
Yeah.
Like you wouldn't answer a question if it said, hey, loser. No one would go for that one.
BS-ometer.
I believe in good medicine and giving everyone a chance.
We're pegging the needle here. It's way over. Yeah.
Anyways, my dear BFF, can you ask Dr. V? Oh, wow. The whole thing is just an art.
Yeah.
If I'm a patient of yours, of course, if you're a patient of mine, I will ask Dr. Victory. No questions asked about that. I will not be the one doing it on my own. If I'm a patient of yours, but get a oh, satellite clinic question, will you get the images? Oh,
Yeah, we did that.
but you know what they did here? They gave a good intro and they knew I'd go for it. So you got double. So I hope you're here listening.
Yeah.
Because I will not answer that question again. Like the intro got to be great the next time.
It's got to be amazing.
Yeah. Going to Instagram for our Instagrammers. Is it okay to exercise and stretch during and after an egg retrieval?
Well, we had that similar question earlier. Yeah, just nothing intense.
Usually in our intro for the show, before we're there's always that little bit with Larry David talking about jostling the fetus.
Yeah, that's right.
And we debunked that.
Yeah, we debunked
but the only
that.
day we don't play it, that question's coming up. Funny. 22% DFI. Other parameters are great. 160 count, 58% motility, 4.6 morphology. Does this DFI warrant a TISA with a history of 0 blasts?
Dear God, no. If you had a history of 0 blasts, that's different. But you can reduce your DNA fragmentation easily. Number 1, no smoking, no drinking, no drug use. Number 2, daily or every other day ejaculation nonstop. Number 3, loads of vitamins. Number 4, cold therapy. Number 5, ejaculate twice on the same day, 3 hours apart. The second sample has 80% less DNA fragmentation. And then finally, number 6, make sure that your clinic is using a device like Zymet or the lens hook device, which will drastically reduce the amount of DNA fragmentation. If you're thinking, or your lab is thinking, that the DNA fragmentation is the result, you didn't get the blastocyst development or blastulation, then that's what you should do. Correct your DNA fragmentation. There's lots of ways to do it. You do not have to do a TESE sample. But if they don't think it's the DNA fragmentation, there are studies that show that extracted sperm, like a TESE or a PISA sample, can fix the problem with achieving blastocysts when you've previously failed with ejaculated sperm. So that's not an unreasonable choice, but it wouldn't be my go-to. I would try all the other stuff first, and then see how you do. Again, it depends on how much you want to spend, how many rounds of IVF you want to do. I would be talking in depth, not to your doctor, but to your embryologist, to see what they thought the sperm was like when they did the IVF. And that's a big thing that a lot of people don't do. We have very liberal access to our embryology team here. We want them interacting with our patients. The patients feel better hearing directly from them, hearing what they thought. I'm not in the lab injecting sperm. I have no clue what they saw or how they did it. But the lab needs to be available to patients in other clinics in order to speak to them, to say, look, your sperm was crap, or your eggs were terrible. I spoke to a patient today that made, she said, between 50 to 60 eggs, and she was told they were poor quality. And I was like, okay, like, what was wrong? You had smooth endoplasmic reticulum aggregates, vacuoles, dark cytoplasm, granular, thick zona. She goes, I don't know. They just told me I had bad eggs. Like, oh my God, how can you not know what's wrong after you gave them 60 eggs? This is insane. These people need to be educated by the clinic. It's the clinic's responsibility to tell you. When we have a cycle where patients don't do great, I sit down with them. I go line by line. Here was your stim. Here's how long you did your stim for. Here's the dosage that we use. Here's why. It was the right dosage. It was the wrong dosage. If it was the wrong dosage, I tell them I think it was the wrong dosage. Here's what happened with your trigger. Here's what happened with your success. You've got to go through this stuff line by line, outcome by outcome, explain how many eggs they got, what the eggs looked like, what the sperm looked like, so patients actually understand why they got the outcome they got. I had another patient recently who did IVF with the clinic in Toronto. She said, can you look at this? It doesn't make sense. Like, I think she had like 9 or 10 eggs and she only got 5. Well, I went through the stim sheet and she very clearly had ovulated halfway through the stim and had released her eggs, and they never told her. Like, how can you not sit down and explain things to people? You have to be honest with people. You have to own your mistakes. You got to make it right when you don't do it right. And even if you did everything correctly, patients deserve to know what happened and why it happened. So you've got to explain that stuff to them. Oh yeah, it's like sinking down.
Yeah, keep it out.
I'll just clip it.
Yeah, just clip it.
Go ahead.
Oh. 22% DFI. Oh, we did that. What are the optimal TSH, T3, and T4 levels for egg quality?
So you're TSH less than 2.5. T3, they're saying between usually like 2.5 to 5. It depends on which reference range you use. And there's some data that's saying a slightly higher level or in the higher end of the range might be beneficial for egg quality and fertilization and blastulation. So we're going to have a video on that soon. And then T4, I think the lower limit is 8 and the upper limit's usually like 22 to 24. So somewhere in that range.
The TikTokers are sleeping today. I'm just letting you know. Not enough hearts flying on the screen.
Sorry, TikTok. More hearts.
More hearts.
Talk to us. Tell us how things are going.
How long should you wait to transfer an embryo after the removal of an 8-centimeter endometrioma?
Oh, well, we would put you through our endo protocols for probably 3 or 4 months. That's a big oma.
High.
And don't let them give you estrogen.
So as I read this, I wonder, should I proceed? All I get is high, smiley face.
Okay. Well, you know.
Like I said, I'm fair. I'm fair to everyone. I won't ask all your questions.
Humble.
But I will give commentary on presentation. Is a high IgG level, particularly IgG4, a concern when preparing for an FET?
That's a great question. So I looked this up recently. There is some data showing that the immunoglobulin levels may impact success rates, but I haven't seen anything specifically on IgG. And overall, it looks like it's probably the IgE that's probably the most important, but there is some weak evidence on that. So I think that data is probably in the works. People are looking at it and doing research. I'm not aware of anything yet that's like definitive.
And this one just did a shoot right into the question. Would.
Yeah.
Not even.
No pleasantries.
Nothing.
I get it.
Hey,
right.
Take it.
That's all right.
Would 225 IUs of Menopur for 5 days and 300 IUs for 6 days be considered a high dose stem with Clomid not doing gonal?
No, but it's wrong because you're getting too much HCG, which makes the smaller follicles not grow. So that makes no sense. Menopur, in my opinion, you should never go over 150 units. You should always keep it lower and then mix it with Recaval or Follistim or Puragon or Gonal-F or any of those other products that are recombinant. But the more Menopur you give, the more HCG you're getting, and HCG retards the growth of smaller eggs. So you don't want to do that.
How long can you low dose stim for a stimulated FET if no progesterone and LH spike?
How long can you low dose stim a stimulated FET if your LH doesn't spike and progesterone?
If no progesterone and LH spike, yeah.
Oh, I wouldn't go more than like 20 days max. And that would be going really long, like really, really long.
I have 2 healthy boys because of you. I cannot thank you enough. I still watch your videos out of curiosity and loving the knowledge and compassion you share.
Oh, that's sweet. Thank you. Appreciate that.
If someone has low level HCG at 4 weeks and doctor stops meds for full medicated cycle, stops meds for 4 days, but puts you back on meds because HCG kept going up, could that lapse of 4 days, no meds, cause a miscarriage around 6 to 7 weeks?
Unlikely. I mean, there's no evidence I can point to for that. So unlikely would be my answer because your pregnancy is pretty good at making its own hormones, but I'd need to know more details, know what your HCG levels were. And of course, if your HCG levels were initially low, that can be predictive of either ectopic or failure or miscarriage. So I would want to watch you very carefully.
I just want to say thank you for offering your services in Windsor. If not, I had to travel to London or Toronto, which we already did, me and my husband, for knowing you.
Oh, well, thank you. You know what? Windsor deserves to have great doctors and royal kings and all that stuff. So
yes,
yeah,
absolutely.
so
I like what you did there.
Windsor's been very good to me. I will never ever forget how good Windsor has been to us. We have had 20 amazing years here, more than 20 amazing years here. And I am very, very enamored of this tiny little city and love it. And it's been great. Yeah, I'm not going to complain. Raised my kids here, established my family here, created what is now a juggernaut business with 70 employees here. We just hired another ultrasound tech. Thank God. Oh my God, Madison, I love you if you're watching. And yeah, amazing.
Long live Majesty King T. Right? Sounds good.
Wow.
I don't know how I go home. You know, I generally don't know how I go home.
Do you want me to get like a palm leaf from now on?
I'm feeling that's the right vibe at this point. Long live.
You need a toga and I need a palm leaf.
I'm accepting of all offers. I will not say no. And honorable Dr. V.
And honorable Dr. V. Yeah.
Of course.
Yeah.
Where would we be without Dr. V?
All right.
I'm just taking it in.
I know you're
just
taking it in.
Totally taking it in. Long live Majesty King T. This is my new BFF. I'm moving BFFs around here. Long live. Wow, it's good.
Get to the question. Man.
What are your thoughts on NAD, subcutaneous injection for egg retrieval prep? Better than supplement form? Safe to do for egg retrieval prep?
Yeah, it's supposed to be amazing. Actually, we're considering doing it. So my naturopath attended a webinar on this and she sent it to me. I just haven't had time to watch it yet because I was working on this new AI infertility thing most of the weekend, but I hopefully will watch it soon. And that looks amazing. Yeah.
Hi, docs. Back to docs.
Back to docs.
Yeah. What is your take on doing half ICSI and half natural selection for fertilization? Thinking about your video about the egg accepting the right sperm.
Yeah. We don't do it. I got a buddy in Toronto, Dr. Fred Zaneku, who I think the world of, who does that all the time. I'm not a believer, but I mean, my ICSI team is so good. They're getting generally like 80+% fertilized. So you can't get that with natural fertilization. So we don't do it, but other places do.
How can I get a SIS ultrasound when each cycle there is never a radiologist on at WRH?
You shouldn't be going to WRH for an SIS. You should be coming to us. So just get a referral to us. We do 6 a day, soon more. So I just ordered another ultrasound machine. We set up a room. So you should just be coming to us. Easy.
What are the chances of tetrazoospermia creating a viable embryo? Is there a chance that it can still fail with ICSI?
So it's terado, not tetra. Teratozoospermia.
First of all, let me just so you know,
it says tetra.
I'm simply reading TETRA.
Oh, well, that's wrong. It's teratozoospermia.
Yes, so guys, teratozoospermia.
Tetrazoospermia would be if you had four
sperms in a zoo. I assume 4 sperms in a zoo.
So, teratozoospermia does not necessarily mean that you're going to have an abnormal baby or a failure. We've got guys with less than 1% morphology, which is very low, high levels of teratozoospermia, and they still produce normal embryos. It's harder and you have lower success rates and the outcomes are not as good as someone that's got great sperm, but it's still possible. You just need an embryology team that's painstakingly willing to sit there for hours sometimes and pick the best sperm one by one.
People are wondering if this is recorded.
This is not pre-recorded. This is live, but we record it and then it gets put up on YouTube later. But right now we're live. Like everything you're asking me, I'm answering in real time. It is currently 8:50 p.m. Tuesday, October 28th. There you go.
Including the sperm in the zoo.
Including
4 of them specifically.
Including the 4 sperm in the zoo.
I have a fresh egg donor.
Yeah.
Who is doing a directed cycle for me.
Awesome.
She is 29.
Okay.
AMH around 3. My clinic recommended not to do PGTA, saying the science does not support PGTA donor eggs.
Yeah.
What do you think?
So listen, we do a lot of donor eggs because we support a large group of patients that require that both inside and outside of Canada. I think we're actually the second largest in Canada for provision of donor services, and will likely soon become number one. So with that in mind, we do it because a lot of our donor egg cases also need surrogates, and the surrogates don't like getting embryos that have not been PGTA tested. And I will tell you that there are more abnormalities in the donor arena than you would think. So it should be really low, but it often actually isn't. And so I actually am a believer in doing it for that group of patients.
Is it okay to fly after a transfer?
Yes, it's fine to fly, or stewardesses would never get pregnant.
Yes. Stewardesses wouldn't get pregnant. Real life science. That's where I live.
There you go.
Hi, Dr. V. Will I need to redo cycle monitoring for a second egg retrieval?
Well, I need to redo cycle monitoring. You will for the stim, not like natural cycle monitoring again, as long as it hasn't been more than a year.
Do you recommend vaginal probiotics before
Yes.
transfer? What type, any brand, and how long?
We use NFH Flora, but any type is fine. Yeah, like any good vaginal probiotic is fine. I don't support NFH Flora over any other product. That's what our pharmacy carries. That's what we put in our prescription system, but you can choose any one you want. And I absolutely don't favor one over another.
Legends deserve brownies. Thank you so much for all you both do. Enjoy.
Is that Heather?
That's Heather.
Heather, brownies are freaking insane. They're so good. You know what? You literally should just market those brownies. That is $1 billion business, those brownies. They are mentally good. So good. Love them. Thank you.
They are amazing.
Yeah. Good enough that we have to beat away the staff.
Yeah, that's a whole other story.
A whole other story. Yeah.
36.
Okay.
PCOS.
Yeah.
AMH 80.
Yeah.
Recent
80?
80.
Whoa.
AMH 80. Recent retrieval 42 eggs, 39 mature.
Yeah.
30 fertilized.
Yeah.
13 blasts. But only 4 were able to biopsied. Only 4 were biopsied.
Why?
Thoughts on this?
I would need to know why they could only biopsy 4, like what happened to your blasts. So give me more details. DM me if the show ends, because we're 7 minutes from finishing.
Can you do a modified natural if you have adenomyosis? I've done 2 medicated FETs which have failed, looking at other options.
Your camera's off. If you have a medicated FET for adenomyosis, I would argue that that's wrong from the beginning. You either do letrozole or you do natural, and we would advocate for our endo protocol. So it wouldn't make sense to do anything else. Again, in my opinion, you're best off to do a natural cycle or do a letrozole cycle. Doing a medicated cycle with adeno inflames the adeno. That's maniacal. Why would you do that?
If it's any constellation, I also second your opinion.
Excellent.
Yeah, I thought that was important to mention.
Yeah.
Do you see a lot of low quality eggs due to the endometriosis? Will IVF make it worse?
So yes, we do see patients with lower quality eggs when they have endo. That's been categorically proven. There's no question on that. There are multiple aspects of the egg quality which get impacted. We have a really good endo video where I was giving a talk. I forget what it's called, but it says like endometriosis, what your doctor isn't telling you. And it's like me giving a talk at last year's Canadian Fertility Show. And you should watch that. It's got all the information about everything you need to know about endometriosis. So yeah, we do see that. From the standpoint of, what to do about it, it's tough to fix that. So it's hard to fix, but there's no question that it impacts egg quality 100%.
Hello. We're both 39 with normal fertility tests.
Okay.
But my husband can't maintain an erection, weight 145 kilograms.
Whoa.
We plan to start IUI. Do you recommend this? And should he see a urology specialist?
So he could probably just see his family doctor and get Viagra, and that should work, or Cialis, or one of those, products. But more importantly, I would say that if he's 145 kilograms, the sperm quality will not be good. There's no question. That's very clearly demonstrated in the literature. And so there is likely other problems there than just the inability to maintain an erection. There's going to be sperm quality problems. So, drastic weight loss is important for his well-being. So I would be talking to someone about that. These days with GLP-1s available, like, weight loss is easy, guys. It shouldn't be difficult.
Does having hypothyroidism in pregnancy mean your pregnancy is high risk?
No, you just have to control it. It doesn't make it high risk at all.
What do you check for if suspected immune-caused miscarriage? NK cells?
NK, Tregs, NK cytotoxicity. You look at your cytokine levels. You can look at DQ alpha. You can look at your LAD levels, and then you can look at KIR. So those are the groupings we look at.
Hi there. I'm doing my first FET in November, and I was wondering what are your thoughts are for natural versus medicated cycles. 35 years old, single female, and did egg retrieval due to low AMH. Never tried getting pregnant.
So we know that medicated cycles have the lowest chance of success and the highest risk of failure. So we never advocate for that. So letrozole has the highest chance of success, the lowest chance of miscarriage, and then a natural has the next highest chance of success and next lowest chance of miscarriage, and then medicated has the highest chance of failure and the highest chance of miscarriage. So we don't advocate ever for doing medicated. We very rarely do a medicated cycle, very rarely.
My clinic uses Clo OQ, oocyte quality. Clo oocyte quality, CHLOE. Yeah, I don't know. AI to score the quality of patients' eggs. Have you heard of this, and do you think it's reliable?
No, none of those things work well. There was another company started by a friend of mine. I think it's called Violet or Purple or something like that.
Green.
I don't think it really took off either. None of these things work well yet, so it doesn't help you in any way. Plus, who cares? So your egg's not great. Are you going to not fertilize it because it's not great? That doesn't make any sense. Like, who cares if the egg is normal or not? If it's a great egg or it's a bad egg, it's all you've got. You're going to fertilize it. You're going to use it. So how does this help me? Could it help me rank the embryos? Maybe, but then I would want an embryo ranking system like Life Whisperer. I'm not going to want one that ranks the egg because that doesn't help me at all in any way. So I don't find that stuff useful. I think it's a waste of money and it's a waste of time. And logically speaking, it doesn't make sense that you would need to do anything about that. I have no idea. Did we die? Is the battery gone?
Somehow the battery's gone. Come on, give me this.
You want me to come sit next to you?
Just sit here. Make life easy.
All right.
Dr. Victory, would you please?
Sure. We're going to skip over to this chair. I guess we never plugged that camera in. I haven't sat in this chair before. This is weirding me out.
It's a weird spot.
Any more? Oh, I got to read the questions myself.
No, I got some here.
I don't know what the hell I'm doing here.
No, don't just focus with me here.
Yeah.
What high blood pressure medication do you recommend during pregnancy?
Labetalol or Adalat. I'm all confused about which camera to look at now.
Look here. But you're looking good.
Thank you.
Does suppression medication truly help with success rates for a FET awaiting PGTA testing results?
In an endo patient, yes. If you combine it with the right combination of suppressing agents. I've got one here I should probably ask. Let me do this one. Hi, which produces more eggs, follicular or luteal stem? There's no evidence that one produces more than another. And then there's another one that says, my FET for my last embryo at your clinic is ending in a miscarriage. I'm very sorry. That's terrible. HCG only dropped from 195 Saturday to 175 today. How long should it take to get to zero? Trying to do a funded cycle ASAP. First of all, I'm very sorry for what you're going through. That's awful. If you took meds, it should be fast. If you did not take meds, it can take weeks. So just talk to your nurse or talk to me.
Can you improve morphology and how?
Sperm morphology? Sure. The same four things I mentioned earlier. Frequent intercourse and ejaculation, no smoking, no drinking, no drugs, zero. Make sure you're taking fertility vitamins for guys, and then make sure that you are keeping your testicles cold. Easy.
Had a concealed placenta abruption.
Oh.
Placenta was small. Would DNA fragmentation cause that?
Oh, great question. No evidence for that I'm aware of. But I wouldn't be surprised if there was an association, but I'm not aware of any evidence. 9 o'clock.
9 o'clock. I'll give you one more.
Okay.
Does suppression medication truly help with success rates for an FET?
What just happened?
Don't worry, you're still good here.
I don't know what I did. Does suppression medication what?
Does suppression medication
truly
help with success rates for a FET?
Yes, for sure. If you have endo. Anything else?
Oh, well, there's a lot more.
Nah, I think we're good.
Okay.
Well, ask one more. Let's go.
One more. Here we go.
Sure.
38 got pregnant naturally after miscarriage from IVF transfer. I have 2 BGT day 7s and I'm 41.
One more time. What was that?
38.
Yeah.
When she was 38, she got pregnant naturally.
Yeah.
After a miscarriage from IVF transfer.
Okay.
I have 2 PGT day 7s.
Yeah.
And I'm 41.
Yeah.
That's it.
That's it?
That's the question.
Day 7 PGT euploid embryo still has a very low chance of success because it's a day 7. So unfortunately, it's not as robust as we would like it to be. Okay, so signing off for tonight. Thank you all for joining us. Sorry for the camera mishap at the last second. Lovely to see you guys all again, and give us some feedback about this idea. We're thinking about letting people actually come on the show, like to jump in on the various platforms to ask us questions. So let us know what you think about that. Do you want a chance to show yourself live and ask your questions live? Let us know. And next week, we'll probably talk a little bit about the Canadian Fertility Show, get some feedback from you folks, what you thought was good, what you thought was not great, so we can help out Marissa Thompson, who runs the show. And I had a great time with that show because I gave a talk called Fertility 2035, what fertility would look like 10 years from now. And it was fun.
Yeah, it's on YouTube.
Is it on YouTube already? Mm-hmm. Cool. Check out that video, guys. Have a great night. We will see you next week on Fertility Fact or Fiction. I have no idea how you stop this.